Hi everyone, welcome back to the UWorld Nursing channel. My name is Samantha. I'm a nurse here at UWorld, and today's live is going to look a little bit different than our typical question drill. So instead of that typical Wednesday question drill, we're going to be walking through each step of making
Hi everyone, welcome back to the UWorld Nursing channel.
What is a
My name is
concept map?
Samantha.
First
I'm
things
a nurse
first.
here at
A
UWorld,
nursing concept
and
map is a
today's
way for
live is going
nurses
to look
and nursing students to plan nursing care around a particular medical diagnosis. So it's a pretty common assignment that may be given to a nursing student as part of class curriculum or maybe clinical paperwork from your shift in the hospital with your preceptor. So depending on what class or clinical you are creating this concept map for, it may be based off a real life client, a case study, or just an overall disease or disorder. So we can organize our nursing concept maps a few different ways, including by the 8 basic needs, like things like comfort and safety, nutrition, psychosocial needs, etc. Or it can be organized by nursing intervention, things like diagnostics and labs, patient teaching, treatments, and medications. This is how we are going to organize our map today. So let's go ahead and get started. First things first, you have to make a concept map. Where do you start? So you're going to start by choosing one disease process in particular. For today's concept map, we chose preeclampsia. We started doing this a few months ago with hyperthyroidism, which is a relatively simple condition. Then we covered more challenging topics in the renal system, like CKD, in the neurological system with TBI, and even mental health topics like schizophrenia. Today, we're shifting gears into an OB topic. We covered postpartum hemorrhage in the past a few months ago, but I find preeclampsia to be slightly more challenging. So maternal and OB topics are going to slightly differ from our other concept maps. You're going to see the biggest differences in the diagnostic section, those nursing diagnoses, and signs and symptoms. Another thing to keep in mind overall is that need for maternal and newborn bonding is really important in those immediate postpartum days. And when we have something like preeclampsia, that can delay that from complications, maybe if the baby goes to the NICU afterwards, if there's preterm delivery, preeclampsia can really pose a lot of issues in those psychosocial needs with the bonding needs of a mother and her newborn. So we're going to start on the left side of the concept map with our pathophysiology. This is a great place to start on any concept map. You'll cover the etiology first and then work your way clockwise throughout the intricacies of the disease process. So starting with patho, here is where we are going to dive into the genesis of the disease process at hand. So we can start out by defining it. Pretty simple. So we're going to define preeclampsia as the hypertensive disorder of pregnancy. I'm just going to put hyper-T disorder of pregnancy. And that is going to be diagnosed as high blood pressure greater than or equal to 20 weeks of gestation. So we're having that high blood pressure that happens after or at 20 weeks of gestation, and we're going to see it with either proteinuria, just meaning protein in the urine, or signs of end organ damage. And that's going to manifest through some of our lab values. So another great thing to do in the patho section is to include the risk factor for that disorder. So the risk factors for preeclampsia, some of the things that predispose us to preeclampsia, include chronic hypertension. So I'm going to put chronic hyper-T that we had before pregnancy, any prior history of preeclampsia. So if a maternal client had preeclampsia with a prior pregnancy, especially multiple prior pregnancies, they're at a higher risk to get it again. Any client with concurrent diabetes mellitus, as well as our clients with multiple gestation, so like twins and triplets and so forth, if you can even imagine it. Alrighty, so we're working clockwise. So next up are going to be our signs and our symptoms. So these are all of the clinical manifestations of the disease process at hand. Here you want to be as descriptive as possible and make sure you list out everything you can find about potential manifestations. The more, the merrier. Be specific here. So the manifestations of preeclampsia specifically are split between those indicative of preeclampsia with or without severe features. That is how we divide this today. So we'll start out with the more mild preeclampsia without severe features, So pre-E without severe features. And again, this is the more mild manifestation. So we're going to see BP here is going to be greater than or equal to 140/90 or greater. We're going to see this with protein urines, so the element of protein in the urine, that proteinuria. We test for this using a 24-hour urine test, which we're going to talk more in depth about in the next section. And then we divide this between pre-E with severe features. So we're getting a little bit more serious here. This is the more complex manifestation of preeclampsia. Here we're going to see blood pressure that are greater than or equal to 160/100 or greater. We're going to see signs of thrombocytopenia is a potential manifestation. Alrighty, so those platelet count is decreasing. We're going to see an increased creatinine. We need to monitor those LFTs or liver function tests. These are our ALT and our AST, which we're going to see increased. And these clients often present with visual or cerebral symptoms. So we can have headache, we can have some little spots in our vision, some blurriness. These would be signs of rising blood pressure and would really concern us about an impending stroke or seizure. So diagnostics and labs to monitor. So this section varies greatly depending on which disease process you have chosen for your concept map. Diagnostics can be things like CT scans, X-rays, MRIs. These scans are going to be especially important for diseases or disorders of the neurological or musculoskeletal origin. Now, some disease processes, especially ones including endocrine issues or hematological issues, are really going to rely on lab work to assess the extent of the issue. Now, preeclampsia is a mixture of monitoring lab values, taking frequent vital signs, and of course, measuring and assessing for those cerebral and visual symptoms in the client. We're kind of taking a whole body or holistic approach here. So many of the signs and symptoms of preeclampsia will actually also be a part of our diagnostic criteria. So first things first, what are our labs to monitor? What are we keeping an eye on, keeping in close contact with our phlebotomist here? We're going to go ahead and look at those LFTs. So elevated LFTs are going to be a sign of preeclampsia. Now, these are liver function tests. It's AST, which stands for aspartate aminotransferase, or elevated ALT, which stands for alanine aminotransferase. So this is our AST and our ALT. These guys can really skyrocket in severe preeclampsia, showing that we're having some damage to the liver. Now, platelet count can decrease. We can be below that 100,000 mark there. So we really have to make sure we're also doing our CBCs, getting a good look at where the platelets stand. This can be especially dangerous, especially if the client needs things like an epidural or a C-section, making them more likely to bleed. And we're also going to assess for that proteinuria. So proteinuria is defined as greater than or equal to 300 milligrams of protein in the urine. And how we test for this is called a 24-hour urine test. So it starts out with the client voiding, but really important note here, the first void is discarded. It marks the beginning of the 24 hours, but we don't include that urine in the test. That's when the test starts. We spend the next 24 hours collecting all the urine in a hat within the toilet. We then pour that into a jug that we keep over ice for 24 hours. Once we hit that 24-hour mark, we take all of that urine that we've been keeping over ice and we bring it on down to the lab. I was an antepartum nurse, so I did a lot of this, and let me tell you, it is a fabulous arm workout. We also want to make sure we're keeping a close eye on our vitals to monitor. Alrighty, obviously we are going to be monitoring the blood pressure. This is a hypertensive disorder. So we're really going to be closely looking for those blood pressure measurements above or equal to 140/90. A lot of hospitals will have protocols of when we get an out of range number, which typically is 160/110. If it's above that, you have to retake it in 15 minutes, and then you start the hypertensive protocol. So blood pressure is really what separates the severe feature preeclampsia from the non-severe feature preeclampsia. So moving on, we have our nursing diagnoses. So this is potentially the most complex and difficult part of your concept map. Now, nursing diagnoses use an organization called NANDA who produce the official list of nursing diagnoses. Now, you can go to nanda.org for more information for that full list of diagnoses, but a complete nursing diagnosis consists of 3 separate parts. The first one is just the NANDA approved nursing diagnosis. In our case, we're going to walk through this using fluid volume overload, which is one of the things we are most concerned about with these preeclamptic clients. They get really, really swollen sometimes. So definitely something we have to look out for. So you can find the official list of NANDA diagnoses on their website. You can also check your nursing school curriculum. Sometimes that comes included with the bundle. So before you purchase anything, make sure you don't already have access to it. But first things first, our NANDA approved diagnosis is fluid volume overload. Part 2 is the related to section. So this section directs the nursing diagnosis to what is causing the issue. So what's causing our fluid volume overload? In this case, it's going to be caused by the increased blood volume of pregnancy. So related to increased blood volume of pregnancy. Pregnant clients do have a larger blood volume to compensate for the fetus that they are growing. Total blood volume, or TBV, increases by about 40 to 45% during pregnancy. So a huge increase here. This is what's going to contribute to that overall fluid volume overload and can also contribute to these high blood pressures. So part 3 would be our as evidenced by section. I'm going to denote that as AEB. So this is asking, what is our clinical proof of this? How can we prove it? So if you're making this concept map using a case study, look to your case study for clinical manifestations that support your nursing diagnosis. If you're making the concept map regarding a clinical shift in the hospital, look at your client-specific results, vitals, labs, and statements as your evidence. And again, be as specific as possible. As a general rule, something like 1250 milliliters of blood loss would be a perfect evidence if that's what the clinical data supports, because it's a much stronger piece of evidence than just saying blood loss in general. Same thing as if you say blood pressure of 88/45. That's a better and more specific piece of evidence than simply stating hypotension or low blood pressure. Here, our evidence can be something like BP of 165/110. That is out of range. 65/110. We could also, in this case, use edema as a sign of fluid volume overload. We may have pulmonary edema. It's whatever your clinical data supports. Last thing, we're going to string all 3 parts of those nursing diagnoses together. So in our case, this first one would be fluid volume overload related to increased blood volume of pregnancy as evidenced by a blood pressure of 165/110. Now, a couple other nursing diagnoses we could use for preeclampsia include impaired urinary elimination. And just so you guys know, we will switch before we're over to a typed version of this in case anyone can't read my handwriting. But impaired urinary elimination could be related to poor perfusion to the kidneys, and some evidence of this could be like an hourly output of 15 mils an hour. We're looking for at least 30 ideally. Another thing that could happen would be ineffective family coping. Remember, we talked about that impaired psychosocial bonding we can have between the maternal client and the newborn client if they are separated. Maybe mom stays in L&D because she's so severe, and maybe the baby goes to NICU. So in this case, ineffective family coping could be another one that we use. And we could do related to separation of maternal client and newborn client in NICU as evidenced by the client stating, "I miss my baby," or whatever the statement or clinical data supports. Other things we could also include would be impaired tissue perfusion, decreased cardiac output, or risk for unstable blood pressure. Now, overall, to note, our risk for nursing diagnoses are not considered as strong as ones that list an actual manifestation that has already occurred or is currently occurring. We try to limit those risk for nursing diagnoses. Typically, we want to keep it at 1 to 2 per concept map, no more. In this one, we only included 1. But now we're going to move on to our nursing intervention section. So this is the section where we list out our nursing interventions to help maintain homeostasis in these clients and prevent their condition from worsening. So important to be as specific as possible. Preeclampsia is really heavy on assessing closely as changes in the condition can present very quickly, and we need to take prompt action when necessary. So some of our key interventions will be our good friend magnesium sulfate. I'm just going to put mag sulfate. Now, we'll go into a little bit more depth on this in the treatment and medication section, but this is seizure prophylaxis. And a really big point here, this does not have a marked effect on the blood pressure. We give it as seizure prophylaxis. I feel like that's kind of a misnomer as an antepartum nurse. It does require really close assessment to prevent magnesium toxicity. This is a high alert medication. It can depress the system, it relaxes the system as a way to prevent seizure, but this can also depress our reflexes, those DTRs. It can also depress our respiratory system and our respiratory drive. So we really have to be closely watching that. We have to closely monitor our intake and our output, as well as those vital signs. Other side effects of MAG include being flushed, hot, sweaty, just generally uncomfortable. I had a client describe it to me as having one too many margaritas, but not getting any of the fun side effects and getting all of the gross, feeling bad, feeling hot kind of side effects. Now, most maternal clients will stay on this magnesium sulfate drip until 24 hours post-delivery. Big safety check here. Again, this is a relaxant. It helps to kind of relax us, prevent that seizure activity, but in turn doing that, it can actually make postpartum hemorrhage more likely in a postpartum client. So that uterus after we give birth contracts, it cramps, it should be really hard and really toned to clamp off that bleeding. If it's relaxed and not as toned as it should be, that's where we can see excess bleeding. So their fundal checks postpartum are always important, but for a postpartum client on magnesium, it is even more important. We have to be assessing that fundus, rubbing it, making sure it is nice and firm. Alrighty, hourly intake and output, another big thing here. When you're on MAG, there's typically a protocol with every hospital. We would have to do hourly vital signs checks, auscultate the respirations, check for any of this intake and output, and of course assess if the client was having visual or cerebral symptoms. But I's and O's are really important here. We of course worry about perfusion to the kidneys. We're tracking what's going in and most importantly, what is coming out. We want to see at least 30 mils an hour of output, and if we don't, that is a cause for concern. The good thing about mag sulfate clients is that they are bed bound, so they typically have a catheter. It is not good practice for them to be up and walking around, so if there's an order for a bedside commode, I might try and see if you can get one for a catheter, but it's an easier way to track that output is the good news. Of course, we're checking those refluxes like I just talked about, but we're checking that for multiple reasons. We're kind of looking on both ends of the spectrum here. So really brisk refluxes are a seizure indication. We're really worried about it's a sign of an impending seizure. High blood pressure puts a client at risk for this. On the flip side, slow refluxes are a sign of magnesium toxicity. Again, it's a depressant. It can depress our reflexes, slow our reflexes. The big danger of mag toxicity is respiratory depression. So slow reflexes can kind of be an impending sign of magnesium toxicity, which means we're at risk for respiratory depression. So we're checking our reflexes in these mag clients, not only for quick ones, which means that they could be seizing, they could be having blood pressures creeping up, but also on the slow side could mean they're becoming mag toxic. Now, obviously, this is pretty intuitive, but anytime we have a client with high blood pressure, we want to administer some antihypertensives, and we will cover pregnancy-safe antihypertensives in the next section. But we'll talk about that more in depth. We want to closely monitor the blood pressure. Typically, this will be hourly assessments. And there's usually a protocol as well for most preeclamptic clients on mag sulfate drips. And last but definitely not least, seizure precautions. So any client that's at risk for seizing, they're on a medication that's seizure prophylaxis, we have to enact our seizure precautions. So we are padding the side rails of the bed. We're removing anything that's sharp that could injure them if they were to seize. There should be no restrictive clothing. We want to monitor them for headache and blurry vision. These could be signs of impending seizure, high blood pressure, and prepare for it if it were to happen. If it does happen, we lay the bed flat. We're going to call in some buddies, and we are going to document the duration of the seizure and avoid putting anything in the client's mouth. Also, betamethasone, we're going to cover a little bit more in the next section, but that is going to be really important for that fetal client in the case of a preterm delivery. All right, it is hard to talk and write at the same time, but y'all did great on this one. This was kind of a dense section. Now let's move on to our treatment and medication. We're going to be med heavy for preeclampsia, but this is the section where the treatments and the medications that help address the root issue of the disease or disorder are discussed. Now, many medications, of course, will be nurse administered, but most procedures are going to be healthcare provider performed. Really, here's where we get into the meat of what the healthcare team does as a whole to help these clients and prevent their condition from deteriorating. For preeclampsia, treatment looks a little bit different because remember, in OB, we're working with two clients at once. We have our maternal client and our fetal client all kind of wrapped up into one. Typically in an OB setting, we want to keep that maternal client pregnant for as close to that 40-week mark as possible. But there does come a point in preeclampsia where the risk to the fetus is higher in utero than it would be getting delivered early and going to the NICU. Essentially, preeclampsia can make the fetal environment in utero unsustainable. High blood pressures also put us at risk for things like placental abruption, restricted fetal growth, and they can even, unfortunately, lead to fetal demise, which is why the treatment for severe preeclampsia is delivery, even if it's preterm. But before we get to that point, we can try a few interventions to try and keep the client pregnant for as long as possible. So severe pre-E, we are looking at most likely preterm delivery. That is just kind of what the case is. And before we deliver the client, there's a couple of things that we can do. So we can give those antihypertensives that we briefly talked about, but not all of these are going to be safe during pregnancy. So the ones that we can give would be a labetalol, that is a beta blocker medication. We can give a hydralazine, which the trade name for that would be apresilene. Nifedipine, which is a calcium channel blocker, and the trade name for that is Procardia. Now, what is one antihypertensive, really common one that we absolutely cannot give during pregnancy? That would be an ACE inhibitor. It is a teratogen. We're not giving this to any pregnant client or any client that is considering becoming pregnant. All right, so now we gave our antihypertensives. We talked a little bit prior about our mag sulfate and just how handy that is going to come in, but it is seizure prophylaxis. It has a minimal effect on BP, but in this case, it's given via an IV drip. Typically, we have a loading dose being 4 grams or 6 grams, and then a maintenance dose, which may be something like 1 to 2 grams per hour. But the maternal client will usually stay on this 24 hours post-delivery in most cases. Now, these are all about preparing the maternal client. What do we do to prepare the fetal client? Well, we give a little shot called beta, which is short for betamethasone. So this helps to develop those fetal lungs. Now, the last thing to develop in the fetus around 36 to 37 weeks are those little fetal lungs. We want to give them the best chance to breathe independently if they are to be delivered preterm. It's essentially like a little kickstart for those lungs. How we give this is via IM injection to the maternal client, and we give it in 2 doses. Now, ideally, we're going to give this 24 hours apart. Unfortunately, sometimes things get so severe so quickly that we don't get a full 24 hours in between doses. In that case, we would give it 12 hours apart or whatever the provider orders. So 2 doses, 24 hours apart, and then a little note in our heads, ideally 24 hours apart. Alrighty, moving on to patient teaching. So what information as nurses must we ensure the client knows prior to heading home? What things should they look out for with certain treatments or medications? What lifestyle modifications are they in need to make? For most clients with preeclampsia, the delivery of the newborn and the placenta treat the disorder and the blood pressures will gradually return to normal. For some clients, preeclampsia can persist into the postpartum phase, taking 4 to 6 weeks to go back to normal. And for some clients, preeclampsia can even present initially in the postpartum period, which is kind of wild. But due to this, we have to educate all clients on what to look out for as signs of preeclampsia or postpartum preeclampsia. So making sure we're telling them to report to the provider if they experience any of these guys here. So any persistent headache that just doesn't quite go away, maybe the Tylenol isn't really cutting it here. So persistent headache would be one. Visual changes, so any kind of floaters in the vision, any cerebral changes, any kind of weird, funky things that you're seeing, as well as quick swelling or weight gain is a big one, especially in the hands, the feet, and the face. This kind of goes hand in hand with that fluid volume overload that we talked about, but we really have to monitor that. Like something like 2 to 3 pounds in 1 to 2 days would be a big cause for concern. So we're monitoring for these changes while a client is pregnant and through that postpartum phase, because postpartum preeclampsia does happen. Alrighty, so other. Now, depending on the disease or disorder that you chose, there will be information that you feel just doesn't quite fit into any of the other boxes. And this is a great use of the other box on the concept map. So in the case of preeclampsia, we'll use this section to educate clients on potential complications that preeclampsia can cause. So these can affect both the maternal or the fetal client. So we will divide it as such. So let's start out with our maternal complications. Alrighty, so things we can see caused by preeclampsia include AKI, or acute kidney injury. We can see pulmonary edema occur. These clients are at risk for ischemic stroke, those high BPs. We can have liver failure or liver rupture. And again, this is why we keep such a close eye on those liver function tests, or LFTs. We can enter something called DIC, or disseminated intravascular coagulation. This essentially is when the body consumes its own clotting factors, putting clients at risk for bleeding. And of course, preeclampsia is the precursor to eclamptic activity. We can see eclampsia develop from this, which is just seizing or seizure activity. That one's pretty intuitive. And lastly, something called HELP syndrome, which is an acronym. Drop it in the chat if you know what it stands for. But HELP syndrome is an acronym that stands for hemolysis, elevated liver enzymes, and low platelets. And as you can tell, this mirrors some of the symptoms we already have in preeclampsia, but this is something that is very severe, definitely a reason to be delivered, but it is a possibility that can happen from preeclampsia. All right, fetal complications. So what can happen to this fetal client as a result of this preeclampsia? So we can see placental abruption. Essentially, the placenta is unable to withstand these high pressures and it starts to peel off the uterine wall. So in this case, placental abruption, it can be partial or it can be full. Sometimes even just like an edge can start to lift off, but a full abruption would absolutely be an obstetrical emergency. We can see restricted fetal growth, which you often see denoted as IUGR. So if you've ever seen that on a chart and you didn't know what it means, that is what it means. Essentially, that environment in utero is unsustainable. It's not allowing this fetus to grow. We can see preterm birth, which in a lot of cases is indicated for the treatment of preeclampsia. And we can see, unfortunately, fetal demise, especially if we do not seek prompt health care. Alrighty, so that concludes our concept map. Way to go, you guys. Our last step is to check before submitting. So make sure you read over your entire map before you submit. Some instructors are willing to look at it before you submit, let you know any weak areas that need additional attention. You can always ask your instructor if they are willing to do this. In closing, thank you so much for joining. I'm going to go ahead and jump to the typed version in case anyone could not read my handwriting. Feel free to screenshot this, take it with you. Again, if you missed this, this will be posted to our YouTube channel after we're done, so you're always able to use it. I know at the end of a semester sometimes is not quite as concept map heavy as the beginning of a semester, so even if you just want to bookmark this for January, please do. Thank you so much for tuning in today. I had a fabulous time with you all, and hopefully you all learned something. Bye-bye.